Finally, I want to chat a little bit about Parp inhibitors, which I think represent one of the beginnings of personalized therapy for prostate cancer and are linked to genetic testing, particularly for tumors. And when we think about the genetic analysis of tumors, I think about this landmark paper, which is now 4 years old, where about 150 biopsies were obtained from men with advanced metastatic castration-resistant prostate cancer. This was really revolutionary work. In leukemia, this is old hat. You can draw blood for leukemia and analyze these cells routinely, and our leukemia colleagues have been doing it for decades. But in prostate cancer, this was really new because analyzing particularly bone metastases has been technically quite difficult, and biopsies have not been routinely obtained. This is a very detailed map of what was seen, and I'm not going to go through it in detail, but what you can see in the columns is individual patients. So this is actually data from individual human beings. It's not some sort of summary data. And across, you see alterations in various genes. And so at the top, you see a lot of color, and those are really commonly altered genes. The top of the line is the androgen receptor. This is a testosterone-driven disease, so it's really common to have extra copies of the androgen receptor or mutations in the androgen receptor, et cetera. P53, P10, and the so-called ETS genes are really commonly altered. But down below, you see a lot of rare mutations that don't occur in many patients, but when they do occur, they may open the door for individualized therapy. That result led us to think about the possibility that inherited genetic defects are more common than previously suspected. And Colin Pritchard reported this paper the next year in 2016, showing that about 12% of men with metastatic prostate cancer harbor a cancer predisposition mutation that may be relevant both for their therapy and choices of treatment, but also for their family. And so we've begun to offer routine testing for inherited genetic mutations for men with advanced prostate cancer as a result of this report. How are we using this biomarker data to treat patients today? Well, we have pembrolizumab, a PD-1 inhibitor immune therapy, approved for patients who harbor a particular DNA repair deficiency, also known as microsatellite instability. This is rare in prostate cancer. We see it in a couple % of patients, but when we do see it, we expect to have a good chance of a significant response to this form of immune therapy. Parp inhibitors are drugs that can be effective for patients with mutations in another class of DNA repair genes, particularly BRCA2 and BRCA1. Those of you who've paid attention to breast cancer have heard of these breast cancer predisposition genes. They are now known to be very important in prostate cancer as well. I've already mentioned gallium PSMA imaging as potentially useful in selecting PSMA-directed therapy. There are lots of other molecularly targeted therapy trials. This is just an example of the NCI MATCH trial, which is offering specific molecular agents for a variety of defects. So when we sequence a patient's tumor deeply and find these rare mutations, one of the things that we look to is this trial to see if there's a novel agent available for that particular patient based on the genetic sequence. But I think using single drugs for single mutations is unlikely to be a definitive solution to prostate cancer. I think we're going to need multi-agent targeted therapies just like we do in infectious diseases. And to that end, at OHSU, we've launched a trial called SMMART, which stands for Serial Measurement of Molecular and Architectural Responses to Therapy. This started in breast cancer, but in the near future, we're going to open a prostate cancer arm. And this trial differs from other approaches in that we analyze not just the DNA and RNA in the tumors, but we look at protein levels, we look at cell structure with electron microscopy, and we aim to use more than one targeted drug simultaneously and rebiopsy a tumor fairly early into therapy, maybe 4 to 6 weeks, to see what's going on biologically and try to adjust our therapy if we begin to detect the early development of cancer adaptation to our treatment before there is overt cancer progression.